2:30 నేను చెప్తాను.
శ్రీకాంత్ సార్ గుడ్ మార్నింగ్. స్టార్ట్ చేసామంటారా సార్?
గుడ్ మార్నింగ్ గణపతి. ఒక్క 2 minutes ఆగి 8:05 స్టార్ట్ చేసేద్దాం.
సరే.
స్టార్ట్ చేసా గణపతి.
సార్ ఒక 2 minutes.
ఓకే.
సార్ స్టార్ట్ చేసేస్తాను సార్. సార్
ఓకే గణపతి సార్ ఉన్నారు.
Okay. Today I'm going to discuss about anesthesia for renal transplantation. Chronic kidney disease. According to KDISAO, it is defined as structural or functional abnormalities of kidneys for more than 3 months, has manifested by kidney damage with or without decreased GFR as defined by pathological abnormalities markers of kidney damage, including abnormalities in the composition of the blood or urine or abnormalities in imaging test, and kidney transplantation, history of kidney transplantation, or either GFR less than 60 ml per minute, 1.73 meters square for more than 3 months with or without kidney damage. CKD is classified based on GFR into 5 stages. Stage 1, if it is GFR more than 90, it's classified as normal or high. If GFR is 60 to 89, it's called slightly decreased or stage 2. If GFR is 45 to 59, it's classified as 3A or mild to moderate decreased CKD. If it is 30 to 44, it's classified as 3B or moderately to severely diseased CKD. If it is 15 to 29, it is classified as class 4 and severely decreased CKD. If it is less than 15, it classified as 5 or end-stage renal disease or kidney failure. Causes of CKD, pathological causes and physiological causes. Pathological causes are glomerulonephritis, interstitial nephritis, tumors, transplant rejection, and congenital disease of the kidney. Physiological causes are hypertension, diabetes, chronic urinary tract infections, congenital abnormalities, vascular disease, and hypertension. Hypertension and diabetes are the most common cause of CKD nowadays. And physiological consequences of CKD, hematological abnormalities. These patients usually have normocytic normochromic anemia. It might be due to decreased erythropoietin, bone marrow depression, and decreased survival of RBC, nutritional deficiency of iron and folate, and chronic upper GI bleeding. And these patients usually have increased parathyroid hormone. It can lead to fibrous tissue of the bone marrow. And compensatory changes are increased cardiac output, decreased blood viscosity, increased 2,3-diphosphoglyceride, and esteosis. These all lead to oxygen distribution shift to right. These patients usually have increased bleeding time because of the decreased von Willebrand factor release and deranged platelet activity and functional defect in the platelet von Willebrand factor interaction, and dysregulated arachidonic acid and prostaglandin metabolism. Also dysregulated. It can lead to impaired synthesis and release of thromboxane A2 and a reduced platelet addition and aggregation. And these patients have increased nitric oxide production from the endothelial cells. It can lead to defect in platelet aggregation. These patients usually have normal count, prothrombin time, and prothrombin PTT and INR. Fluid balance. Chronic kidney disease causes dysfunction in regulating water homeostasis because of the reduced GFR, RAS activation, and secondary hyperaldosteronism. Volume overload is slightly prevalent in patients with CKD because 10 to 30% increase in the extracellular fluid can be detected, and fluid overload results in edema, hypertension, electrolyte imbalance, and also have impaired concentrating ability, cannot compensate for extra renal losses. So these patients usually have hypotension and hypovolemia. Electrolyte abnormalities. These patients usually have hyponatremia, hyperkalemia, hypocalcemia, hyperphosphatemia, hypermagnesemia, and metabolic acidosis. The most common cause of electrolyte imbalance in CKD is hyperkalemia. Serum potassium concentrations are maintained within normal limit until GFR approaches 10% of normal, at which point hyperkalemia manifests. Remaining nephrons compensate aldosterone secretion and increase in CKD, leading to increased potassium excretion. This compensatory mechanism can be oral. The risk of hyperkalemia in CKD patients mainly increased potassium uptake, either dietary or IV or blood transfusion and GA bleeds. And there will be increase in potassium levels because of the intra to extracellular shift of potassium in some drugs like scoline, beta blockers, sepsis, and esteosis and insulin deficiency. And decreased potassium excretions are mainly in constipation, potassium sparing diuretics, AC inhibitors, and heparin. Calcium and phosphate metabolism. Patients usually tolerate hypocalcemia remarkably well. And these patients usually advised calcitrol and calcium carbonate. Kidney failure can lead to decreased GFR. It causes decreased phosphorus excretion and increased serum phosphorus. On the other side, there will be decrease in activation of vitamin D. It leads to impaired calcium absorption from the gut and decreased serum calcium. It activates the prothrombin hormone release. It causes the bone demineralization and it increases the serum calcium and serum phosphorus. The patient finally land up in metastatic calcifications. Metabolic acidosis. CKD leads to metabolic acidosis due to reduced functional kidney and inability to excrete acid load. Metabolic acidosis is a common complication of advanced CKD, present in 30 to 50% of individuals with GFR less than 30 ml per minute per 1.73 meter square area. And metabolic acidosis is defined as bicarbonate levels less than 22 milliequal per liter. It is aggravated by hypovolemia and hypotension. The consequences of the metabolic acidosis are bone demineralization and muscle mass loss, insulin resistance, and RAS activation, renal damage, and residual renal functional worsening by decreasing GFR and increasing serum creatinine. Serious manifestations. These patients usually have higher chance of ischemic heart disease because of accelerated atherosclerosis and decreased plasma triglyceride clearance and hypertension, fluid overload, arterial calcification. These patients usually suffering from uremic cardiomyopathy, uremic pericarditis, cardiac failure due to hypertension, fluid overload, anemia, acidosis, presence of high flow AV fistula created for dialysis access. These patients usually have arrhythmias due to acidosis, hyperkalemia, and conduction abnormalities. Pulmonary manifestation. These patients usually have pulmonary edema because of the increased hydrostatic pressure like fluid overload and LV failure, decreased oncotic pressures in hypoalbuminemia, and increased pulmonary capillary endothelial permeability in chronic infections. And these patients will usually have pleural effusion and hyperventilation due to metabolic acidosis, increase the lung water, and poor pulmonary compliances. Gastrointestinal symptoms are delayed gastric emptying, anorexia, nausea, vomiting, upper GI hemorrhages. Central nervous system manifestations are ranges from mild alteration in personality to asterixia, myoclonus, convulsion, and encephalopathy. Peripheral neuropathy occurs later as CRF worsen. It is initially a distal glove and stalking sensory loss leading to motor involvement. And these patients usually have autonomic neuropathy. It causes delayed gastric emptying, hypotension, and silent myocardial ischemia. Immune manifestation. Inhibition of cell-mediated immunity and humoral defense mechanisms occurs with little improvement following dialysis. Superficial infections are common in fistula catheter site. Wound healing is poor. Effects on drug pharmacokinetics in CKD, opioids, fentanyl. It undergoes extensive hepatic metabolism. No active fentanyl metabolites. 7% excreted unchanged in urine. So it causes action prolonged. Morphine. It metabolizes in liver to morphine 3 gluconate 70% and morphine 6 gluconate 5%. Morphine 6 gluconate has analgesic property and elimination depends on renal function. Half-life is prolonged in CKD. Tramadol 30% excreted and unchanged in urine has active metabolite that is excreted by kidney. So action of tramadol is also prolonged. Intravenous induction agent, thiopental, reduce protein binding in CKD that causes a higher free drug concentration. So dose to be titrated to the effect. Propofol, pharmacokinetics unaltered by CKD. Benzodiazepines and other sedatives. Midazolam gets metabolized in the liver. The main metabolite is 1-hydroxymidazolam, which has similar sedative activity to the parent compound. This and the other conjugated metabolites can accumulate in renal failure with infusion leading to prolonged sedative effect. Dexmedetomidine, pharmacokinetics not influenced by renal impairment. Sedative effects may be stronger due to lower degree of plasma protein binding. Neuromuscular blocking drug, succinylcholine. It can be used provided there is no hyperkalemia. Suxamethonium can increase serum potassium by 0.5 milliequal per liter because of the reduced action of plasma cholinesterase. Vecuronium, 40% excreted by the kidney. The 3-hydroxy metabolite accumulate in renal failure. It has 80% of potency of vecuronium. So there may be a prolonged neuromuscular effect. Rocuronium, 10 to 20% excreted by the kidney, and there will be no active metabolite. Atracurium, cisatracurium, undergo Hoffman elimination, the drug of choice in CKD. But ladenosin can accumulate with prolonged atracurium infection. It causes neurotoxicity and convulsions. Reversal drugs, neostigmine. Renal excretion accounts for approximately 50% of plasma clearance of neostigmine. Clearance is reduced in CKD and half-life is prolonged. Inhaled anesthetics, sevoflurane. Controversy in CKD because metabolism results in elevated inorganic fluoride levels. More than 50 micromole per liter were associated with renal damage in animals, but not seen in humans. And sevoflurane also reacts with carbon dioxide absorbent to form compound A, which has found to be nephrotoxic in rats, but not in humans. So sevoflurane can be used in patients with CKD. And desflurane, isofluranes are safe in CKD. Analgesics. Drug of choice is acetaminophen and NSAIDs. They are nephrotoxic agents that decrease renal prostaglandins and precipitate an acute decrease in GFR and may also cause acute intestinal nephritis as a part of idiosyncratic reaction. There is also increased risk of GI bleed, so it should not be used in CKD. Management of patient with CKD. This patient usually on restricted protein diet with 0.2 to 0.0 gram per kg per day, and restricted salt intake should be less than 1.5 to 2 gram per day. This patient usually on antihypertensives, and these patients on a diuretic to treat hypervolemia. This patient advised vitamin D and calcium phosphate binders. This patient usually have metabolic acidosis. To overcome these patients are advised bicarbonate, erythropoietin to treat anemia, and statins to treat hyperglyceridemia. Renal replacement therapy in end-stage renal disease are hemodialysis, peritoneal dialysis, and kidney transplantation. Kidney transplantation is the treatment of choice. It is better to preemptive before dialysis. Transplantation done when GFR less than 20 milliliter per minute per 1.73 meters square. There is a progressive irreversible deterioration over 6 to 12 months. Hemodialysis require a stable access to the bloodstream for dialysis to be performed. 3 major types of vascular access are primary AV fistulas, AV grafts, tunnel hemodialysis catheters. Temporary vascular access used during maturation of AV fistula, typically in the right jugular vein. Access generally is placed in the non-dominant upper extremities, as lower extremity placement is associated with increased risk of infection, arterial steal syndrome. AV fistula versus AV graft. AV fistula, joining a vein to an adjacent artery directly. It has higher long-term patency rate and lower complication. It takes around 4 to 6 weeks to mature. AV graft, prosthetic graft to connect an artery and a vein. Long-term patency is inferior to AV graft, and it has 6 times greater thrombosis rate compared to AV fistula and 10 times greater infection rate. It can be used earlier within 2 weeks. Indications for dialysis are pericarditis, pleuritis, progressive uremic encephalopathy or neuropathy, clinically significant bleeding, diathesis attributable to uremia, fluid overload, refractory to diuretics, hypertension, poorly response to antihypertensive medication, persistent metabolic disturbances refractory to medical therapy like hyperkalemia, metabolic acidosis, persistent nausea and vomiting. The process of dialysis. Blood is pumped through an extracorporeal system that incorporates a dialyzer. In the dialyzer, blood is separated from the crystallized solution by a semi-permeable membrane. Solute move across the membrane along their concentration gradient by diffusion. Urea and potassium move from blood to dialysis, while bicarb move from dialysis to blood. Typically, session for 3 to 4 hours results in 65 to 70% reduction in blood urea. Problems associated with dialysis are volume related. It causes excessive fluid removal, can land up in hypovolemia, solute mediated alkali shifts and alkemia, anticoagulation related bleeding, dialysis disequilibrium syndrome. Neurological symptoms caused by rapid removal of urea during dialysis. It causes reverse urea effect. The urea concentration in the CNS remain elevated because of its slower diffusion from the CNS to the blood than the diffusion of urea from the blood into dialysate compartment. It causes the osmotic gradient between the brain and blood. Finally, patient land up in cerebral edema. It's called dialysis disequilibrium syndrome. Dialysis versus renal transplantation. Kidney transplantation, it improves quality of life and long-term survival and is more economic option than both hemodialysis and peritoneal dialysis. Comparison of patient survival after dialysis after transplantation. Blue line is dialysis and red line is transplanted patient. The survival rate is more in a kidney transplanted patient compared to dialysis patient. Anesthetic management of a patient with CKD for renal transplant. Usually 220,000 people require kidney transplantation in India. 7,500 transplants are done across 250 centers in India. 90% from living donors, 10% from deceased donors. Type of donors, kidneys. Deceased donors and living donors. Deceased donor, relatively urgent procedure due to time limited viability of the donated kidney. Living donors, we can post as an elective surgery. Type of disease donor, standard criteria donors. These patients usually young and without any comorbidities. Extend criteria donor. These patients usually oldest group and with multiple comorbidities. And disease cardiac death. Donor in whom cessation of cardiac function occurred before organs were procured. Preservation of deceased donor kidney. The donor kidney should be preserved in static cold storage at 0 to 4 degrees centigrade. The kidney immersed in preservative solution. The hypothermic environment and the preservative solution causes decreased cellular metabolism and provide cytoproduction. The preservative solutions are collision solution, urocollision solution, University of Wisconsin solution, HTK, histidine, and tryptoma solution. It can be kept for 24 to 48 hours. Living donor. This donor carefully evaluated, and the advantage of the living donor increased donor pool available. Living donor renal transplant is an elective procedure and the timing of operation is flexible. Kidney transplanted from living donor show an increased graft survival. Donors candidate should have GFR more than 90 milliliter per minute per 1.73 meter square. Exclusion criteria for living donors. Age less than 18 years, abnormal GFR compared to normal range for age, and proteinuria more than 300 milligram in 24 hours, uncontrolled hypertension, type 1 diabetic mellitus, microscopic hematuria, IgA nephropathy, high risk of thromboembolism, medically significant illness, autosomal dominant polycystic kidney disease. Donor recipient matching. Matching has to be done between the donor and the recipient to ensure immunological compatibility. Blood group matching, ABO compatibility. Tissue matching with 6 antigen of the major HLA complex. 6 antigen matching represent best compatibility with the lower risk of rejection. Cross matching between the recipient serum and donor T cell to detect presence of antibodies in the recipient against donor cells. Contraindication for transplant for recipient. Absolute contraindications are active infections, active malignancy, active substance abuse, reversible kidney failure, uncontrolled psychiatric disease, predicted patient survival less than 2 years. And relative contraindications are systemic conditions that may have caused kidney failure, primarily oxalosis, systemic amyloidosis with cardiac involvement. And a relative contraindication of cardiac or history of myocardial infarction in the past 3 to 6 months, progressive symptoms of angina, non-amenable to angioplasty or bypass surgery, severe CKD, not amenable to intervention, severe ischemic cardiomyopathy with ejection fraction less than 30%. Pulmonary conditions are home oxygen therapy requirement, uncontrolled asthma, severe car pulmonale, severe COPD, fibrosis, and restrictive diseases. Anesthetic management of renal transplant. Pre-anesthesia. Patient should be asked for symptoms of breathlessness, pedal edema, chest pain, palpitation, and exercise tolerance. Usually, these patients have reduced exercise tolerance, and we should ask for cause and duration of the CKD and history of diabetes, hypertension, CAD. And this patient usually we should ask for a usual daily intake of and urine output. Medication history. We should ask for antihypertensives. These patients usually on AC inhibitors, diuretic, calcium channel blockers, beta blockers, alpha-1 blockers, and alpha-2 blockers. And we should ask for bicarbonate dose. Dialysis details. Type of dialysis, whether it is peritoneal, hemodialysis, site, AV fistula, AV graft, or internal jugular vein. Duration of dialysis. Longer the duration of dialysis, concern about the vascular access. It may cause a stenosis, thrombosis of the central vein, or numerous AV fistulas affect the venous access. And we should ask for frequency of dialysis once, twice, or thrice a week. Time of last dialysis and body weight before and after dialysis. Examination. We should look for pallor, bleeding tendency, edema, and vital signs, hypertension. Check for autonomic neuropathy and cardiovascular system, flow murmurs, and respiratory system, crepitation, basal crepitation, and location of AV fistula and dialysis lines. And we should assess airway management. Preoperative optimization, correction of anemia, erythropoietin, eptoin alpha 20 to 50 international per kg thrice a week, subcutaneous or IV. If HB less than 10 milligram per deciliter, or darbepoetin 0.45 microgram per kg once every week, subcutaneous or IV. Risk of hypertension, stroke, vascular accident or more. Acceptable hemoglobin level is 10 to 11.5 gram per deciliter. We should correct the high blood pressure and high blood sugar, coagulopathy, and optimize the cardiac and pulmonary conditions. Preoperative optimization and pre-medication. Preoperative dialysis the day before surgery, 24 hours before, at least 6 hours to elapse between dialysis and start of surgery to optimize fluid and electrolyte and acid-base balance. Continue antihypertensive cardiac medication. AC inhibitors are usually withheld to reduce risk of intraoperative hypotension. Acid aspiration prophylaxis should be given. Adjacent theaters. Live donor nephrectomy and renal transplant operations are commonly performed sequentially in adjacent theater with minimal delay to reduce ischemia time of the donated kidney. It can be done under laparoscopic or open surgeries. Anesthesia for living donor renal transplant nephrectomy. Usually left kidney is preferred because of the better surgical exposure and longer vascular supply. And these patients usually on lateral decubitus with bed flexor to expose and arch the flank. It may cause the nerve damage, pressure sore, airway compromise, and venous access compromise. Anesthesia for laparoscopic donor nephrectomy. General anesthesia with endotracheal intubation and controlled ventilation. With using fentanyl 2 microgram per kg, propofol 2 mg per kg, and vicodinum on 100 microgram per kg, followed by maintenance with oxygen, nitrous, air, and sevoflurane. Good venous access should be secured for adequate hydration, 10 to 20 milliliter per kg per hour, and balanced salt solution should be used. Maintain perfusion pressure, normoxia, normocarbia, normothermia, urine output of 100 ml per hour, and improve diuresis with mannitol furosemide before renal artery clamping. The kidney is perfused in cold preservative and taken to the recipient. Extubated end of operation. Post-operative pain. Avoid NSAID. Use paracetamol IV. Patient control analgesia with fentanyl, morphine, thoracic epidural, now blocks like paravertebral blocks, tab blocks. Anesthesia for recipient. Vascular access. Good peripheral vascular access is required in transplant surgery to give large volume of intravascular fluid rapidly. Obtaining intravascular access is often difficult in patient on dialysis. Avoid IV access in the hand that has AV fistula. Generally, hemodialysis catheter should not be used for purpose other than dialysis like drug administration, central venous pressure monitoring. Exception is in emergency situation or when alternative vascular access is impossible. Induction and intubation. Pre-oxygenation rapid 6 induction and with use of fentanyl, propofol, succinylcholine. Attenuate the intubation response with free lignocaine IV 1.5 milligram per kg, 90 seconds before intubation. Intubation with the copper oral endotracheal tube. Antibiotics and induction immune suppression should be given at the time of induction. Maintenance with the air, oxygen, SAVO, and desflurane or isoflurane, top up of atrocurium or fentanyl, ventilation to maintain normal carbon dioxide and oxygen levels, maintain perfusion pressure, and avoid fall in systolic blood pressure less than 20 MAP from baseline, maintain normothermia using forced air warmers and fluid warmers, floatron tech stocking to prevent thromboprophylaxis, and AV fistula should be padded. Ischemia time. There are 3 ischemia times: warm ischemia time, cold ischemia time, warm ischemia time in transplant. Warm ischemia time to harvest from the time of clamping renal artery in the donor to the time of efflux of the cold perfused from the renal vein. Cold ischemia time from the time of cold perfusate coming out of the renal vein till the kidney is placed in the recipient for anastomosis. Warm ischemia time from the time of kidney is placed in the recipient to completion of anastomosis and clamp release and beginning of the reperfusion. Fluid management. Adequate volume of fluid has to be administered for renal allograft to function. CVP guided volume infusion has been the traditional approach in renal transplantation, involve intraoperative infusions of fluid to maintain CVP 90 to 10 millimole per HC. Usually 1.5 to 2.5 liter of fluid are administered. Dynamic indices of fluid responses like pulse pressure variation, systolic pressure variation, stroke volume variation can be used to administer fluid in the intraoperative period. Fluid management. Type of fluid. Traditionally, to aid hyperkalemia, only 0.9% normal saline was used as the crystalloid of the choice of CKD in patient undergoing renal transplant. But a large volume of NS are associated with hyperchloremic acidosis, renal vasoconstriction, and hyperkalemia. So balanced salt solution like plasmolite, RL are recommended for infusion during renal transplantation. Hemodynamic management for best graft function. We should maintain CVP between 9 to 10 during clamp release after anastomosis. Blood pressure at clamp release should be more than 90 MAP. And adequate hydration with crystalloid 30 ml per kg per hour or 1.5 to 2.5 liter at the time of clamp release. This has to be infused during the period of anastomosis. Fall in BP at clamp release due to vasodilatation caused during reperfusion by mediators that accumulate during ischemia. Mannitol Lasix not routinely recommended in living donor kidneys. No evidence to support use of dopamine. Immediate urine output. 90% of live kidney donation usually pour urine, and cadaveric donation only 50% of patients will pour urine. Immune suppression. The aim is allograft survival ultimately relies on appropriate home immune system modulation. A lifelong immune suppressor regimen is required after renal transplant. It can be induction and maintenance therapy. Induction with almutuzumab, T-cell depleting monoclonal antibodies, anti-thymocyte globulin, that is T-cell depleting polyclonal antibody, basiliximab like interleukin receptor antagonist, and balatuximab secondary messenger signal inhibitor. Maintenance with corticosteroid, calcineurin inhibitor, antimetabolites like mycophenolic acid, azetioprine. Vasopressors. Epinephrine and phenylephrine not recommended to treat hypotension. It causes vasoconstriction of the renal allograft. Norepinephrine used if there is a severe hypotension, not responding to other treatment, as maintaining perfusion pressure become more important. Blood transfusion. It causes alloimmunization, so it is not recommended routinely. Better to correct anemia pre-operatively. CKD patients have chronic anemia, so they well tolerated. The transfusion recurrent CKD is 7 grams per deciliter. If major blood losses occurs, use leukocyte filter or leukodepleted blood. Hyperkalemia, increased blood viscosity, transmission of infection or other risk with a blood transfusion beside alloimmunization. End of operation, reversal and extubation. If the kidney is functioning well, most patient can be extubated on table after reversal of neuromuscular blockade and ensure adequate anesthesia. Post-operative care, dedicated post-transplant unit and fluid management. Last house urine output plus 50 ml per hour based on CVP, BP, daily weight, and hemodynamic management. Hypertension is associated with delayed graft functioning. So we should correct hypertension immediately. And analgesic, IV patient control anesthesia with opioids like fentanyl, morphine. The epidural should be put with coverage of T12 to L1, tab blocks, and we should avoid anesthetics. Monitoring urine output, renal function test, and electrolytes. We should continue immunosuppression for lifelong. Thromboprophylaxis, early mobilization, mechanical thromboprophylaxis. And perioperative complications are acute resection, vascular complication like renal artery, venous, renal vein thrombosis, ureteric complication, and delayed graft function, failure of the transplanted kidney to function promptly after transplantation, leading to dialysis within 1 week after transplant. Rates are 4 to 10% with living donor, higher with deceased donor. It can be due to hemodynamic or immunological process. The other complication is acute tubular necrosis. Thank you. Sir, any doubts? Questions, sir? Any question?
Thank you, Ganapati.
Ma'am, good morning.
What is your good morning? What is your experience of renal transplant and CKD patient coming for non other surgeries?
Till now, I have not done any transplant CKD, but I've done 3 or 4 cases of CKD in RK hospital for DJ stenting under spinal only, not GA case. I have not done any GA case.
During PAC, what are the things you have to look and how you are optimize the patient and take the case?
This patient usually have a chronic anemia, so we should look for hemoglobin and electrolyte imbalance, 3 metabolic acidosis, and last dialysis when they have done. And these patients usually have higher chance of infection. Any recent infections are there or not. And pulmonary, like pleural effusion or any pulmonary, mild pulmonary edema, we should look for.
So you are given spinal, no?
Vascular access. Yes.
Okay. You are given spinal, how? You are given a fluids challenge or so normally you are titrate the fluids or routinely normal patient, how you are giving the fluid like this you are given this patient or any changes?
Titrated doses, ma'am, with low dose of bolus we give, ma'am, for CKD. If not responded, then again we will give bolus, ma'am, with low doses only, ma'am, not like a healthy patient. With minimal low doses of bolus, we titrate.
And if general anesthesia, okay. In general anesthesia, what are the precautions you want to take during PAC?
Same, almost. Electrolyte imbalance we have to look.
And ask the
calcium, magnesium.
If possible, is a dialysis day 1 day before the day of surgery, if possible, done or not. So because otherwise, if you are giving general anesthesia and with the drugs is not coming properly, inadequate, also you discuss with nephrologist. Post-op also may need dialysis.
Okay.
I mean, 1 hour case, it's okay. If more than 2 hours, 3 hours case, sometimes is maybe not recovered properly. and don't think about hurry and in the OT only you want to extubate.
Okay.
So see the patient is adequately came or not, you have to see. If not coming, inform to nephrologist, maybe patient need dialysis. Like this you have to think.
Okay.
That is the more important thing. Thank you, sir.
Thank you.
Raman Prasad, sir, ఏమైనా questions?
A patient immediately completed dialysis and now altered sensorium. What is the first step you will do?
Electrolyte imbalance to check electrolyte imbalance.
Hello?
Electrolyte imbalance to check for electrolyte imbalance.
You could do is check blood glucose.
Okay. Hypoglycemia attacks more common in dialysis. Yes.
A known CKD patient operated for AV fistula. In the midnight, get a call that his BP is 90/50. What do you check?
Patency, we look for patency, sir, first.
How do you check the patency?
Via stethoscope, we can hear the sounds, gushing sounds.
Also, palpable thrill.
Palpable thrill.
What are the common preservative solutions for the kidney?
Collision solution, HTK solutions.
Sir?
HTK solution, Euro-collision solution. Histidine.
Even Hartmann solution is also used, no? Not a
Hartmann place.
finger lactate or saline isotonic. Iced. Cold ischemic time and warm ischemic time, how much per kidney dry?
It should be less than 90 minutes. No?
Less than 90 minutes. Right kidney and left kidney, what is the common place where you place?
Left kidneys. Left kidneys, sir, because of the...
Sir?
Left kidney, sir.
Left iliac further.
Left iliac further.
Why left?
The axis is easy, sir, because of the large vascular supply, sir, compared to right.
I don't remember correctly, but vessel is longer on one side.
Yes, longer.
That place is used.
Yes.
What is the estimated urine output immediately after transplant?
1 liter per hour. 1 liter per hour, sir, immediately.
Happy when the output is how much?
1 liter, sir.
Per kg, how much?
Per kg, sir.
0.5 ml per kg per hour.
Point. Okay.
Thank you.
Thank you, sir. Thank you. Madam, any questions?
Ganpati,
Ma'am.
0.5 ml, I think a normal case.
Normal cases, madam.
Renal transplant, I think not acceptable, maybe. Not ideal, much pen.
Yes, madam.
The routine, normal cases, we can acceptable 0.5 ml.
Yes, ma'am.
But renal transplant we can't accept.
Yes.
Okay, next, sometimes delayed recovery
No.
and pulmonary edema
Mm.
because you are dumping the fluids during
Yes.
after clamping the patient.
Yes.
So that time also because your urine is not coming, you are giving the fluids. Sometimes patient gone to pulmonary edema,
Pulmonary edema.
already uremic cardiomyopathy, LV dysfunction is there.
Yes.
So we can't give the fluids, more fluids compared to normal. So
Yes.
that time also may be gone to dysfunction.
Yes,
So these are the complications we can see in the post-op.
Okay.
So next, and a rejection, severe hypotension. These are the things you can see in the post-transplant.
Okay.
Okay, thank you so much.
Thank you.
శ్రీకాంత్ బిజీగా ఉన్నాడేమో.
Okay, ma'am.
Okay, thank you.
Thank you. Thank you.
Thank you to all.
Apart from tab block, what are the other blocks you can give for post-operative analysis?
Quadratum block one.
Surgeries.
Sir, quadratum lumbar.
What is
Quadratum lumbar
block? Yes. Yes. What is Shamrock sign?
Shamrock sign. తెలుసు సార్. ఏం సార్?
నాకు కూడా తెలియదు. అది క్వాడ్రాటస్ లంబోరం బ్లాక్ లోనే వస్తుంది. మిడిల్ మజిల్ ఉబ్బుతుంది అనమాట.
ఓకే ఓకే.
3 మజిల్స్ ఉంటాయి కదా
సార్.
ఒకసారి నేను సెర్చ్ చేసి మళ్ళీ పెడతాను గ్రూప్.
ఓకే.
టిపికల్ రామప్రసాద్ సార్, ఎప్పుడు క్వశ్చన్ అడగలేదు, ఆన్సర్లు ఎప్పుడు చెప్పరు. నా పీజీ ఎప్పటి నుంచి
మోడరేటర్ ఇప్పుడు వచ్చారా
మేడం? ఆన్లైన్ ఎప్పుడు లైన్ లో ఉన్నాం.
మీరు లైన్ లో ఉంటా, మోడరేటర్ ఇప్పుడు మాట్లాడుతున్నారు
మేడం. మీరు అందరూ ఉండగా మేమేంటి మేడం పిల్లలు?
అంత లేదు కానీ పాపం ఈగర్లీ వెయిటింగ్ గణపతి.
బాబు పిల్లల స్టేజ్ దాటి చాలా కాలం అయింది బాబు జయరాము.
అమ్మా ఏంటమ్మా?
పిల్లల స్టేజ్ దాటి చాలా కాలం అయింది అంటున్నాను.
ఈ క్లాసులు ఎప్పుడు పిల్లలవే.
శ్రీకాంత్ షామ్రాక్ సైన్ అంటే ఏంటమ్మా? షామ్రాక్ సైన్
ఎక్కడో సార్,
ఎప్పుడో ఎక్కడో.
కాదు జయరాం, పిల్లోడి కాబట్టే మోర్ దెన్ 30 minutes చెప్పాడు. అదే మీరైతే 15 minutes లో క్లాస్ అయిపోయేది.
అది షామ్రాక్ అంటే అల్ట్రాసౌండ్ పిక్చర్ అనుకుంటా సార్, QL బ్లాక్ లో మజిల్ అలాగా షేప్, మజిల్ ఆ షేప్ లో కనబడుతుంది.
ఎలివేషన్ ఆఫ్ ద మజిల్ సార్, ఏదో ఏ మజిల్ గుర్తులేదు కానీ ఎలివేషన్ ఆఫ్ ద మజిల్, సెపరేషన్ అండ్ ఎలివేషన్.
QL క్వాడ్రస్ లంబర్
నాకు గుర్తుంది.
హలో
బాయ్.
శ్రీకాంత్ ఒక్క నిమిషం.
అంటే ఇక్కడ కేసు ఒకటి ఏదో అనెస్థెటిస్ట్ వాళ్ళ రిలేషన్ కేసు ఒకటి వెంటిలేట్ చేస్తున్నాము, మళ్ళీ చేస్తాం.
ఓకే 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 ఓకే. ఏం లేదు, చిన్న స్మాల్ అనౌన్స్మెంట్. వీఆర్ కండక్టింగ్ CME April 16th లివర్ అండ్ రేనల్ అనెస్థీషియా ఇన్ రాక్డేల్. సో వీలైతే స్టూడెంట్స్ ని, PG స్టూడెంట్స్ ని ఎన్రోల్ చేసుకోమని చెప్పండి.
అలాగే మేడం, మేము కూడా
అండ్ 2 credit hours.
ఓకే మేడం.
ఓకేనా? థ్యాంక్ యూ సో మచ్.
థ్యాంక్ యూ
థ్యాంక్ యూ టు ఆల్.